all of you. Um, I will try to share my screen here. And let's see. Okay, does this show my slides?
Not the way you want them, right?
Okay,
They're showing us the presenter view.
okay. Maybe I will just. All right.
Perfect.
Amazing. Well, I'm very excited to be here presenting my work, quantifying gaps in the tuberculosis care cascade in Brazil. I started this work probably in 2021 or 2022, and have been learned a lot from this process. And as Finn mentioned, I'm a fourth year medical student, so this is not necessarily my background, but have learned a lot working with Professor Menzies. Excited to present this work. So in terms of the goal of the study, TB is a major public health challenge in Brazil, with sort of 100,000 plus estimated cases and 8,000 deaths in 2021. And in particular, amongst the area regional neighbors, Brazil tends to struggle with TB more, and it sort of is amongst one of the top sort of 30 countries in the WHO list of countries that is sort of high, has a relatively high incidence of TB. Challenges in prompt and effective TB treatment in Brazil have included delayed diagnosis, poor treatment adherence, and loss to follow-up. And the Brazilian Ministry of Health has been interested in different sort of health system strategies to addressing the TB burden of disease. And our study was basically trying to identify which elements of the care cascade were contributing most to the burden of disease and identifying gaps in TB detection and treatment using a care cascade model. And we were calibrating and sort of using data from 2018, the national reported data from the TB databases and mortality databases in 2018 from Brazil. So our overall model structure, we used a Markov modeling approach with discrete health states and a 1-month transition period. And basically, the model was segregated into 2 models. The first was for persons with TB, and the second was for persons without TB. The model for people with TB was started at the time of incidence. And so everyone in that model starts in the untreated state. They then can transition to treatment with some probability, which is related to the rate of presentation for treatment, and then the sensitivity of diagnostics, the diagnostic algorithm to sort of identify TB. There's also a probability there of primary or pre-treatment loss to follow-up. And if the individual experiences pre-treatment loss to follow-up, they do not start treatment and end up back in the untreated state. From treatment, individuals can either enter the treatment loss to follow-up state. So if they're lost to follow-up with some rate of transition there, they can complete treatment. And amongst those who complete treatment, there are, and that occurs also with some rate of treatment completion, which was sort of derived from the average time for completing a treatment regimen for either drug-resistant or non-drug-resistant TB, depending upon the stratum. So for those who complete treatment, some of them are assumed to be cured, and some percentage of them are cured, and some with some probability. And then there's some probability of treatment failure after treatment completion. From any state, obviously, a individual can experience death. And then also from all of the non-cured states, individuals can transition to the cured state. For those who are untreated or not on treatment, either in the lost to follow-up state or the treatment failure state, they experience sort of a self-cure rate of transition, whereas those in the treatment state obviously transition to the cured state based upon the rate of treatment completion and then the probability of cure, as we had discussed. The TB model is stratified by drug resistance status and HIV status. Obviously, they're individuals of different ages, and they experience age-related mortality differences as well. And the model is also stratified by early versus late disease. And so the early disease state does not confer any increased mortality. So it kind of represents an early stage of disease. The late disease stage corresponds to increased mortality and then also an increased rate of presentation. So those in the early disease state don't present for care as rapidly, whereas those in the late disease state do. And this is kind of a novel addition to our model, which is to kind of model the differences in health behaviors of those with early sort of lower symptomatic versus later symptomatic stage TB. The model for persons without TB starts at the time of presentation. So this is, we start with basically all of those who present for diagnosis with a non-TB related health condition. They're symptomatic, but they are, or they're presenting for care, but they're TB negative. From there, they can either transition to, based upon the specificity of the diagnostic, either transition to a misdiagnosed TB state or to the correct diagnosis. From the misdiagnosed TB state, there's some rate of transition to the correct diagnosis state based upon both the sort of probability of correct diagnosis during their TB treatment effectively, or the probability of loss to follow-up. And that's the sort of those are the main health states included in our model. So in terms of the diagnostic framework, one of the challenges that we experienced was that we, in order to identify or to calibrate the TB incidence and the TB negative presentation numbers, which are the sort of inputs to the care cascade models, we were only working with Sinan treatment notification data, and Sinan is the sort of national database for tracking individuals who are on TB treatment. But the issue is that since it only tracks individuals on TB treatment, we don't actually have data for those who were who entered the diagnostic algorithm for TB, but then were not diagnosed with TB. And so we lose some of the ability, especially for the TB negative presenters, to identify how many of them were TB negative versus TB positive amongst the treatment notifications. And so basically what we have to do, what we did in order to identify these two categories was to take those with Sinan treatment notifications. We assumed or we sort of derived / assumed some probability, given that given a treatment notification, what is the probability that they were a false positive versus a true positive, and that was derived effectively from sensitivity, specificity, and an assumption regarding the ratio of TB to non-TB individuals presenting for care. And then from that, we were basically able then to determine the percentage of the TB of the Sinan notifications, which were theoretically true positive, true positive versus false positive diagnoses. And then from that, we were able to back derive the size of these cohorts. We obviously use this to derive the size of the cohorts by age, and also we stratified the model, I should have mentioned, by state, so as in region of Brazil. So this was sort of our framework for identifying the input cohort generation to the model. So our calibration approach, again, the data that we used was the Sinan data regarding those who were tracked by the Brazilian Health Ministry who were on TB treatment. So for those individuals, we had data regarding the deaths on treatment. So those who were in Sinan, and then the final outcome for them was death. And then we also had mortality data and the code, the sort of TB mortality diagnosis code. And so we use these two data sets basically to calibrate obviously the treatment notifications by age and state enabled us, as I mentioned, to calculate the incidence. But then we used the Sinan deaths and the Sinan deaths by age and the SIM deaths by state, basically to get senses of the percentage of people who are dying with TB on treatment versus off treatment, because we obviously did not have the off treatment data that was not recorded, but we utilized both of these data sets to kind of give us, to enable us to calibrate basically the rate of presentation for diagnosis, which is the variable that determines basically the fraction who are dying without off TB treatment versus on TB treatment. It has to do with, how quickly are people presenting for diagnosis and hence entering the treatment cascade. The other element that we were able to calibrate from this was the TB mortality rate and the HIV mortality rate ratio, which was modeled as a rate ratio on top of the baseline mortality, whether that baseline mortality was a non-TB baseline or a TB baseline. HIV was a rate ratio on top of that. And we calibrated that for by using the Sinan HIV deaths and it was a single rate ratio for all age groups. And so on the right side, you can see the calibration sort of results. We calibrated pretty directly to the Sinan deaths and the Sinan is in the bottom here, the Sinan on treatment deaths and the SIM, which is the mortality database, the Brazilian mortality database deaths with TB. And then the HIV deaths as well, which was not as good of a calibration fit because we used a single parameter mortality rate ratio for all age groups. But that was kind of our approach to calibration. So the crux of our analysis was looking at these health scenarios where we idealized a bunch of different, we created a bunch of idealized health scenarios in order to understand the burden of disease incurred at each stage in the care cascade. So our approach here was basically to take the baseline performance as indicative of 0% effect or no change, and then an ideal performance would be with the model assuming no TB or no TB mortality. And we, but still including HIV and other risk factors, just without TB. And so what we basically did was we modeled a bunch of health scenarios, and we identified how much effect did that health scenario have in reducing or improving the outcomes of interest, which I'll talk about in a little bit. But we had sort of baseline performance was 0 and the ideal performance was 100%, and so we basically identified the percentage that we report in our results are on the scale of 0 being baseline performance as opposed to being or ideal and 100% being ideal performance without TB and not no mortality or whatnot. So in other words, this is the scale on which we're reporting our results. The specific health scenarios are listed above here. We eliminated delays to diagnosis. So we, and I sort of talk about how we did that from a parameter perspective. We increased the rate of diagnosis, and you can see sort of the key health scenarios that we modeled were related to sensitivity and specificity, treatment loss to follow-up, so either pre-treatment loss to eliminating pre-treatment loss to follow-up, eliminating treatment loss to follow-up, eliminating treatment failure, which I said, there was some rate of completion and then a probability of treatment failure. So we assumed that everyone who received treatment was cured, or who completed treatment, was cured. We assumed no delay in retreatment after treatment failure. So there was part of our model involved individuals who were experienced treatment failure. There was some probability that they were reinitiated on treatment with some identification probability of their treatment failure. And so the reinitiation in this health scenario, we were trying to figure out eliminate the retreatment after, or eliminate the delay in retreatment after treatment failure. So not entering a separate treatment failure state, but rather promptly reinitiating treatment. We also, in our model, focused a lot on post-TB sequelae after TB cure. So there's evidence to suggest that after TB cure, there are respiratory system sequelae that lead to increased mortality even after TB cure, especially for individuals with late disease. And so that was another key difference between the late and the early disease individuals, was that those with late disease had experienced post-TB sequelae even after TB cure. And we modeled eliminating these sequelae and the non-TB reference, as I mentioned. So the outcomes of interest that we were collecting were related to TB disease burden and to cost. For the disease burden outcomes, we were interested in deaths with TB. So this was not deaths from TB, but we were looking at all deaths that were in individuals with TB. And that was also the criteria that we used when we initially calibrated the model to this SIM deaths and SINON deaths. We were looking at all individual all-cause mortality for individuals with TB. We were also interested in TB DALYs. And so that was calculated based upon the projected life expectancy and the disability adjustments for living with TB, living with HIV, and other comorbidities. And then the estimated transmission burden. So we didn't have a transmission model. We weren't looking at incidence associated with transmission, but we were looking at the transmission burden, which we estimated by using time spent with untreated TB. So this is individuals who are not on treatment and have TB. Both early and late TB, we assumed to carry a potential transmission potential. But we said that individuals who were on treatment, even if they were not cured of TB, had a decreased negligible transmission potential in our model. And so from this, we were able to estimate sort of transmission burden. And then for costs, we estimated the health system costs of providing care in each of the health scenarios and in the baseline scenario. And it's worth mentioning that our health system, we did not measure or we did not quantify the costs of actually bringing about the health system, idealized health system changes. So we were not looking at, for instance, what would the cost be to improve the sensitivity of a diagnostic, to its maximum potential. We were instead just looking at, if we do, make those changes, idealized changes, what does that do to the health system costs of providing TB care, including treatment, diagnosis, and sort of those costs of care. And also, we obviously modeled costs of care, and this becomes important for our non-TB model as well, where treatment and diagnosis of individuals without TB is also a major contributor to the cost. So this is kind of the first few figures that we present are related to the baseline performance of the TB health program, and the health burdens, the TB burden in different strata. So we can see the stratified results by state. We quantify here the per person. So per person here means per individual, per incident TB case. So all of these graphs are regarding the TB model, not the non-TB model, but all of these. So this is DALYs per person and case fatality incurred by individuals with TB. And this is by state, and we can see that this was at least in concurrence with some of the expectations of the Brazilian Health Ministry. We also look at this by age group in terms of the per person and total DALYs and deaths with TB, and we can see that obviously when we look at the DALYs per person, there's emphasis on the younger age groups and the burden of disease caused by TB in those age groups. But overall, when we look at overall deaths and DALYs, the middle-age individuals experience the highest burden of disease in aggregate. So the other aspect of the baseline program performance that we wanted to illustrate was, if our desired health outcome for every individual with TB is to be cured by treatment in the early disease state, we wanted to kind of track, what percentage of people were meeting that target. And so if we assume, let's say, a certain incidence at 100%, out of that, something like 90% of those individuals initiate treatment, but a large majority of the people initiating treatment are initiating treatment with late disease. And that has to do with the rate of treatment progression and also the rate of presentation for diagnosis being low for people with early TB. And so this is, this may, this, as we'll see, incurs quite a bit of burden, a disease burden, both with disease mortality, but also with the post-TB sequelae, which are worsened by entering treatment with late disease status. And then out of those, so if 90% are initiating treatment, something like 80% or so are cured by treatment. And again, a large majority of those cured by treatment are cured with late TB. We can see on the right-hand side a sort of geospatial map of the fraction cured by treatment, ranging from anywhere between 75 to 87% meeting this target, with a large majority around 80% fraction cured by treatment. So, looking at the key results for our model in the health scenario, basically this table shows the percent change that I sort of mentioned on that spectrum, from no change being basically equivalent to the baseline scenario, and 100% change being effectively no TB, or the same amount of whatever outcome without TB. Looking at deaths, TB attributable DALYs, or DALYs, and transmission burden. And we can see that overwhelmingly eliminating delays to diagnosis causes the greatest reduction in our TB deaths and TB attributable DALYs, with almost 70% of those outcomes being eliminated while eliminating with no delays to diagnosis. The treatment loss to follow-up was the next best, with sort of around 10 to 15% change in outcomes, or in negative health outcomes, with while eliminating treatment loss to follow-up. And then eliminating false negative diagnoses was kind of was next. Importantly, the eliminating post-TB sequelae after TB cure had a very large impact on the DALYs, on the overall DALYs accrued, and that kind of suggests that post-TB sequelae may be an important contributor to the burden of disease. And it's worthwhile to note that even in the no delays to diagnosis group, because something like in the baseline scenario, something like 20% of individuals are cured with early TB, whereas in the no delays to diagnosis group, almost 80% of individuals are cured with early TB, with the remaining 20% being because of loss to follow-up and then treatment for progression, et cetera. The no delays to diagnosis group, a large proportion of the DALY benefit that those individuals have may be related to post-TB sequelae, because of the overwhelming push or shift between early diagnosis and late diagnosis, or early treatment and early cure versus late TB cure in the no delays to diagnosis group. The post-TB sequelae effect is probably felt in that group as well. So it's worth noting that this post-TB sequelae may be an important contributor in this disease. Or just to point out, eliminating false positive diagnoses. So in other words, the non-TB model did not really have create much of a change in the TB in the total DALYs. So this is not total DALYs. In other words, we did assume that there was some mortality effect to treating people who otherwise do not have TB but have TB-like symptoms, so may have some other disease. There's some mortality sort of deficit incurred by by the fact that they are not on the appropriate treatment, but that does not contribute much to the burden of disease in those individuals. However, the false positive diagnoses do contribute to programmatic costs. So you'll see that the programmatic costs are much less elastic, so to speak, than the burden of disease metrics. They don't change as much with these health scenarios. And in fact, in some health scenarios, they even increase because of increased number of people receiving and seeking treatment. And increased number of people receiving a diagnosis. So because these are health system costs that do not include, hospital admissions and all those things, this is just the health system. This is just the health system cost of providing TB care. More care does, may lead to increased costs. However, we can see that by eliminating false positive diagnoses, we can have there is a cost reduction that is noted that's significant amongst the other health scenarios. And I think that's the major sort of takeaway from the cost outcome. So when we also looked at health scenarios amongst individuals with HIV and drug-resistant TB. And so I should mention that, our model, as I mentioned, was stratified by HIV status and drug-resistant status. We assumed that we only modeled rifampin resistance in our model, and we assumed that everyone, amongst all of the individuals with incident TB, some percentage of them had rifampin-resistant TB. And in our model, we included diagnostics that were, we included some probability of diagnosing rifampin resistance upon initial diagnosis, which was related to the prevalence of gene expert and versus sort of smear at the time of initial diagnosis. And also traditional drug sensitivity tests as well. And so that was kind of the baseline of our rifampin resistance model. The drug resistant model also had two different treatment states. So for those with drug resistance, there was the possibility of entering treatment on an inappropriate treatment state, which was the first line drug regimen, and then and there was some probability of cure using first line regimen. And then there was entering the appropriate or second line treatment sort of arm, and the probability of cure was obviously higher for those individuals. And those who failed first line treatment were then, when their treatment failure was identified, were initiated on the appropriate second line regimen. And so basically, it's worthwhile to note here that individuals with HIV experience much of the same benefit to the overall all comers when it comes to eliminating these gaps in the care cascade. So no delays diagnosis and post-TB sequelae. But the individuals with drug-resistant TB do not experience the same benefit when it comes to, for instance, delays to diagnosis. And I think and it's worth noting here that identifying rifampicin resistance at initial diagnosis does lead to a significant reduction in the DALYs for those individuals. So it appears that a large part of the burden of disease for individuals with drug-resistant TB may not be necessarily solved by just promptly initiating diagnosis, but rather there's probably some importance of promptly initiating the correct treatment regimen and eliminating some of the other gaps, for instance, in delaying retreatment and quickly and appropriately identifying rifampicin resistance. And this is kind of one of the key targets for our the next stage of our work, which is to look at specifically at the drug-resistant group and see if, for instance, expanded access to gene expert across the country may improve outcomes and to what extent might it be cost effective in improving outcomes for this group. I think that was basically the key points that I wanted to discuss for our model. In summary, basically delayed diagnosis, post-TB health sequelae, and loss to follow-up are main contributors to TB disease burden. Post-TB health sequelae may mediate burden of disease caused by other care cascade gaps, and overall, it might represent sort of an understudied source of TB burden, and may incentivize movement towards early treatment, early diagnosis, more so even than just the mortality benefit during the TB phase, but rather the mortality benefit and disability benefit that is incurred after TB cure due to these sequelae of disease. Diagnosis and erroneous treatment of non-TB individuals is a significant contributor to the health system cost, but it's not particularly relevant for disease burden. The idealized health scenarios demonstrate improvement in burden of disease, with the cost of care not really changing as much with these idealized health scenarios. And then closing gaps in the care cascade for individuals with drug-resistant TB may be challenging due to sort of fixed contributors to disease burden, or contributors to the disease burden that are related to the treatment regimens and the lengthy treatment regimens and the difficulty in diagnosing or the gaps in diagnosing specifically drug-resistant TB. And may motivate different strategies for diagnosing and treating individuals with drug resistance. So yeah, I wanted to acknowledge obviously Professor Nick Menzies, who's the principal investigator on the project. We had many advisors from our group and from the National Tuberculosis Program, Ministry of Health in Brazil, and really special thanks to them. I don't know if Daniele was able to join, probably not, but they were obviously a huge resource for us and continue to be a source of advice and support. Love to open it up to questions if anybody has.
Brilliant. Thank you so much, Siva. That was really interesting to see. Straight away we have a question. But yeah, thank you. That was really great work and really nice to see. So Lucy, do you want to unmute and ask your question? I think there's a few enough of us on the call that we can do it that way.
Thank you, Finn, and thank you for the excellent presentation, Siva. I was just interested to understand for the HIV-TB group, if you made any assumptions regarding ART and early diagnosis from expert. I'm not really sure if expert is first line for people living with HIV in Brazil, but I'm just keen to know what assumptions you made regarding that. Thank you.
Thank you so much, Lucy. So for ART, the way we modeled ART was we looked at the adherence of, so we had data for individuals with HIV-TB and whether or not they were on ART. We assumed, we stratified ART adherence by state. So we basically looked at the, we let HIV-TB related mortality vary by state depending upon the fraction of individuals who were on ART when at the time of their recording in Sinan. So we didn't model dynamic changes to ART adherence status, but we did model the differences that by state that may have occurred due to differences in ART adherence. So that was kind of how we modeled ART amongst those with HIV. In terms of early diagnosis from expert, so we didn't stratify, we didn't change the diagnostic algorithm for those with HIV versus TB. So everyone experienced the same diagnostic algorithm. In terms of the split between expert and other sort of diagnostic approaches, in this particular model, we did not, we modeled some of the sensitivity in order to determine the sensitivity and specificity of the overall diagnostic algorithm. We did stratify by the number of people who were diagnosed with expert versus smear, but we didn't really let that vary by state or by HIV status. But that is a target for for sort of some of our next work, which is kind of looking at especially expansion of expert which is a major priority for the health ministry as well. And seeing whether that would, number one, sort of potentially improve the sensitivity and specificity of diagnosis overall, but also improve outcomes for those, especially with drug-resistant TB. So yeah, that's definitely an area that we're trying to model with more rigor coming up in terms of the expert utilization in different strata.
Thank you very much. And while if nobody else has questions, I just had a couple of quick questions. And I think one was hopefully a brief one. I was thinking about the fact that you said that the increase in TB program costs, if you can go back to that, it was was it mostly around delays to treatment, but they weren't particularly big. But what I wondered was if you'd included in that, because I hadn't completely understood how you'd included that sort of burden of TB transmission. So obviously you don't have a transmission model, so you can't say a lot about that. But I wondered if the delays to diagnosis would be bigger if you had explicitly considered that, or if you had already done that and I just misunderstood.
Oh yeah, so the transmission component was definitely not, we did not, for instance, estimate the costs that would, have come from treating individuals who experienced incidents due to TB transmission. So yeah, these costs are explicitly for treating the individual, like the incident case, so it was not looking at the transmission effect. But yeah, that's a good point. I think that these costs definitely are, underestimate some of the health system costs in a lot of ways, certainly via transmission, but also, via we're not looking at, for instance, the, cost of, we modeled sort of the cost of care for individuals with untreated TB, but we're not explicitly modeling sort of hospitalizations or a lot of the, yeah, I think that the cost modeling here was certainly not as extensive as it could be, and may underestimate the costs, especially in the sort of transmission case for sure.
No, absolutely. I was just checking I'd understood that right. Did you, and apologies if I've missed it, you didn't show results for TB transmission, just for the DALYs and deaths and costs?
Oh,
Was that the column?
Did. Yeah, I showed the transmission.
Sorry. Yeah, so that's where I thought that combination of 52% transmission burden averted by the diagnosis, that combined, so I thought that would make the costs, but for that.
Yeah, we did. Yeah, we didn't incorporate the transmission effect in the cost in our cost estimates. So I think that's a good point. The transmission burden was simply, this is like a proxy metric for transmission, which was basically to sum all of the time spent in untreated TB health states across all, across the model. And so basically we got a sense of how, what is the like degree of infectiousness, or how many person years of infectious TB were on the loose, so to speak, and we use that as a proxy for transmission burden, but we didn't really estimate the effects of transmission.
Yeah, no, absolutely. I just think that's an interesting bit. Thank you, Mamapudi.
Hello, and thanks for the interesting talk. So I also had some questions around the cost. I think I may have missed it. So what did you specifically include in the costing of the program?
Yeah, so we included so the costs of diagnosis for sort of TB, normal TB, including like chest X-ray, a clinic visit, so on and so forth, and then also costs of diagnosing drug-resistant TB. And so basically we basically used out of the box estimates for costs of diagnosis. And then the costs of treatment, so there's a specific treatment cost that was per month cost of TB treatment, both again for drug resistant and for non-drug resistant TB. And then the costs of treating, or the costs of taking care of healthcare for untreated TB was also included as a separate estimated monthly cost. And I think those were the major costs that we included in the model.
Can I ask, just my sort of, I think it was right back at the beginning, you were explaining how you did TB incidence and TB mortality of people who weren't diagnosed. And I couldn't quite get my head around that, but I think I was wondering if you would mind very briefly just explaining it again, but also then it made me think about when you had the case fatality rates, if you looked at those split out by whether people ever received treatment or not, because I assume it would be about from the fact that from your delay to diagnosis being 60% of TB deaths could be averted by reducing that to 0 or whatever it was, increasing it to 100%. I assumed it would probably be about 60% of deaths are happening in people who aren't diagnosed. Is that, I don't know if that's something you looked at, but I also wasn't sure. I wasn't sure I'd understood how you'd estimated the incidence and mortality.
So I can definitely speak to the first point. So in terms of estimating the incidence and mortality, yeah, the sort of approach that we used here was the combination of treatment notifications and SANON. So we basically utilized, we looked at the SANON treatment notifications. We assumed that some percentage of those, we had calculated / assumed that some percentage were false positive and true positive diagnoses. So then amongst the true positives, we basically determined the number of people presenting for diagnosis and being positively diagnosed with TB in that sort of arm. And from that number, and then that number, the number of deaths with TB by age group in SANON, so the number of people dying with TB, like those two numbers can kind of give you a sense of the mortality for individuals on treatment. And then the ratio of the individuals dying with TB on treatment versus off treatment kind of allowed us to calibrate sort of the presentation rate, or at least some sense of how quickly are people being how quickly are people being identified and initiated on treatment compared to dying with untreated TB. And so that, I guess, I think that, I mean, obviously the calibration approach was sort of done using a optimization function, and there's not explicit calibration to for each parameter to each of the outcomes, and it was kind of we calibrated all of the parameters together. But that's kind of how I rationalize how the calibration of the and then incidence was sort of calibrated based upon sort of the number of people, number of treatment notifications, and then some sense of how many people are, what percentage of people are presenting for treatment and starting treatment. And again, I think that was related to the number who are dying off treatment versus on treatment being kind of a proxy for the, how many people are eventually initiating treatment, and then giving us a sense of the true underlying incidence of the disease. So I think that was, I don't know if that sort of clarifies that point.
I think so.
Can I jump in on his last question?
Well, can I just before that, just to check? So you use something like, but to get that sort of triangulation, you have an assumption about the rate of death of people not on treatment based on like the Tim Esmer paper or something like that, and that's okay. Okay, I think I get that then. Thank you. Oh, I've forgotten what the second half was. Yes, Nick, sorry.
And sorry, I should also mention that in this model, we do assume that the on-treatment and the off-treatment mortality rate for TB are the same. And the assumption there is coming, obviously that's a big assumption, but those who are on treatment also maybe being the individuals who are presenting for care, and then maybe sicker in general because they're seeking treatment. So yeah, we did make that assumption, which then allowed us to calibrate the TB mortality rate, for both groups kind of together.
Yeah, so Finn, so one thing you said is, because we saw a 60% reduction, if we can kind of wipe out diagnostic delays, does that mean that the 60% of TB deaths are before treatment? And if we just had sort of one type of TB health state, I think that would probably be right. But the thing here is that there's it's simplified, but there's disease progression. So the benefit of fast diagnosis is crudely, you get to people before they die, but also at the same time, you also prevent them developing more advanced forms of disease. And so with fast diagnosis, you reduce both mortality before treatment and mortality on treatment, because the people, in some fantastical world where we find the TB shortly after it develops, TB treatment outcomes will be really good because people, they have very minor disease. So that's kind of what's going on there.
Okay, cool. Oh, it's interesting. Thank you. And so that means the proportion of deaths that are happening in people who don't have treatment is probably much less than 60%, I think.
Yes, I think that's true. Yeah.
Okay. Oh, that's really interesting. Thank you. And so, so that means when you have no delay, that's essentially saying is that saying everybody gets diagnosed, or is that it's slightly different to everybody gets diagnosed? There are still people who don't get.
Yeah, so that's not assuming anything about the diagnosis. I mean, there's still like the sensitivity is not 100%, so there's still some possibility that they end up back in the untreated group. But this assumes that everyone receives diagnosis. But so everyone enters the diagnostic algorithm, but not everyone receives a positive diagnosis.
Okay. Okay. I think I understand. It's lots to think. It's really interesting. Thank you. Does anyone else have any last questions? I think we're running out of time as well, but all right. If not, thank you so much. And thanks again, Siva. That was really, really nice, really interesting to see. And yeah, some really interesting stuff going forward as well with RIF and so on. So we'll keep an eye out for it. I think we do have a talk planned for next month, which I have not advertised yet, which will be Alexandra Denoy. And in fact, if I'm honest, I can't remember what the topic of the talk is. So I'll just say that she's talking at the end of November after the union meeting. Hopefully, I think.
Complexity tests?
What's that, sorry?
Is it low complexity tests?
It could have, I think maybe.
Profiles. It's on the target profiles from WG, yeah.
Brilliant. Thanks, Mama Pudi. Yes, Mama Pudi's suggestion as well. But yes, and I think many of you will be at the union, so I look forward to seeing you there. And remember, there's a TB Mac drinks on Thursday night, which I don't think we've got a venue yet for, but please do come along. It'd be nice to see you all. And I look forward to seeing you on the beach in Bali. Thanks again, Siva, and see you all soon.
Thanks so much, everyone.
Thanks, guys.